Right, this brand is too small, bro.
Dedicated equipment and resources in triage areas, and then, of course, making sure that the actual triage structure, the physical infrastructure itself, is actually well maintained and safe for all entering health patients, their social support networks, and healthcare workers. If you continue to scroll down, you will see then there is a highlighted section that looks at very specific infection prevention and control indicators. Indicators such as training. Are there healthcare workers that are well trained in sort of the various types of infection prevention and control precautions? Are there a set of standardized guidelines that can help inform healthcare workers how to carry out specific IPC behaviors? And then, of course, additionally, but not least important, is looking at, again, items related to the physical infrastructure within this section. For example, is the area specifically within the healthcare facility, is it well ventilated? Is there sufficient space? And are there opportunities to make sure that if things are not well ventilated in space, can they be corrected? The next section that we will see here is specifically looking at hand hygiene. Now, in this particular section, you will start to see indicators that are actually observation focused. What do I mean by observation focused? Meaning that while collecting information within this section of the checklist, you'll need to make sure that you are actually observing healthcare workers as they engage in this activity. Specifically, if you look at indicator 9, you'll see that one of the questions that is being asked is in triage area. It's looking to identify how many functional hand hygiene stations are available in the training and triage spaces. The total number that you would identify, so say for example, you have 4 hand hygiene stations in your triage and screening area, 4 would then become the total number that you have in that area. Then the next question that's associated with that one would be like, how many of these are actually functional? So if you have 4 hand hygiene stations, so say for example, you have 4 Veronica buckets in your triage area, but only 2 work, then you would say that 4 is your denominator and 2 is your numerator to be able to capture this information. Other indicators similar to this are captured throughout this section of the actual checklist. If we continue on forward, we have another section that is devoted specifically to the availability and the correct utilization of personal protective equipment. This particular section asks about stockouts and supply chain mechanisms to ensure that any required resources to keep healthcare workers safe are available to them. Additionally, within this section, you will see such indicators as in number 13 and 15, where again, these are observation-based indicators. The goal here is to try to assess if the actual healthcare worker is sufficiently and adequately wearing the personal protective equipment at the correct time. Again, you will be asked to identify a denominator and a numerator associated with these indicators to be able to see sort of what specifically in terms of behaviors are being conducted by healthcare workers in the primary healthcare facility. In the event that it is identified that healthcare workers are not wearing personal protective equipment correctly, then this provides an opportunity in which to provide corrective actions for these types of behaviors. Stay with me, everyone. We're almost there. We're almost there. We only have like 2 more beautiful sections left. And then, of course, there are environmental cleaning and waste management indicators that are often very much overlooked within the primary healthcare facility and within infection prevention writ large. And you'll see there are specific indicators here that are looking for the actual availability of the appropriate protection for cleaning staff. So for example, 16D, just to give you an example, asks about specific protective gear and availability of personal protective equipment. And then of course, last but not least, at the very end of this tool, you will see a section that's called Essential Services for Continuity. As a lot of you are aware, during acute phenomena like an epidemic or a pandemic that we are currently experiencing, there are oftentimes challenges to continue essential services through these acute emergencies. Oftentimes, programs like our HIV, maternity and child care programs, those services will slow down or be discontinued in an effort to try to make sure that the acute emergency is being addressed. However, one of the most critical things within infection prevention and control and healthcare writ large to ensure the safety of healthcare workers and our patients is to make sure that essential services are continued throughout an acute emergency. This particular section of the checklist focuses on those services that really should be maintained during an epidemic and or pandemic. In this section, you're being asked to compare sort of if there has been a change in these essential services from when COVID wasn't actually occurring in 2019 to when now we are currently in the pandemic phase. So you want to take a look to see if there's been a difference in services uptake and utilization within these 2 time points to see if there's been a reduction in the utilization of these services to try to then take corrective actions. And as you can see here, there are very specific highlighted essential services that have been accounted for within this section. That's actually the completion of this particular checklist. I will also just mention to you very quickly that in the event that any of these indicators are unclear to you, there is also, in addition, a guidance document that specifically and in great detail goes into how to very specifically capture and calculate and to actually collect the data for each of these indicators in the checklist. I would like to thank you very much for your time this morning, and I appreciate you taking an opportunity to familiarize yourself with this checklist. And I'd be happy, along with my other colleagues, of course, the experts like the colleagues in the field, to answer any questions that you may have at the end of this session regarding this tool. Thank you very much.
Thank you very much, Yvette, for that fantastic overview of the checklist. I know that colleagues on the call will have several questions for us. We are excited and we are really hoping to have like an engaging Q&A session. I think we would now move over to East Africa, where we'll be having our colleague from Ethiopia, Dejini Kumela, who will be speaking about the experience from the Ethiopia team. So over to you, Dejini.
Hi everyone. Good evening, good afternoon, and good morning, where you are.
Three wouldn't even be enough for me. I am a very strong man. How much is this one?
Give me £1.
Oh, okay, it's cheap. Hey, give me change.
We don't accept this one.
Why?
You need the English money.
This one is 200. So you won't accept this one. You don't accept it. I will report you to my president. Look at these people. You don't. I'm going to eat your bread though. You know, the thing is that I'm so hungry now. So if you come, I don't have the money to pay. Bring this broom, let me sweep for you. Just Jamal, bring me broom, let me sweep.
Engaged in the IPC practice of that health facility, like setting of agreed visit schedule, because this is not as such inspection, rather it is supportive, rather it is a mentorship program. So we start by setting of schedules, then meet with the health facility at the start of the visit so that they can own the checklist or part of the process. So aware the health facility about the visits, why this visit is important, and collect information about the health as Ibet mentioned, try to collect all the facility information, the health professionals working in that facility, and all available informations. The second level is about site visit, which you can say it's record visits, triage registration, availability of SOP guidelines, and observation of like the PPE utilization, the environmental cleaning, everything. So this is the observation. As you can see from my picture, this is a kind of registration used under the health facility. It is a big registration book. Detail of the client is going to be registered. So the observation part also include this kind of thing in addition to encouraging this recurring system. The third part is based on the first two process, is giving about the feedback. while we do, or the monitors do this feedback, we can categorize it into three. Like the first one is immediate action, in which behavioral intervention like adherence to PPE, proper utilization of PPE, hand washing station, and cleaning, everything that can be managed at spots, can be discussed with individual health professionals, cleaners, and all healthcare professionals working in that facility at that point of observed mistake or observed things to be changed. The second thing that we are doing is identifying issues that needs institutional and the policy level review or amendments for the IPC committee at that specific facility, or issues that need the attention of higher level, for example, regional health bureaus or Ministry of Health, the higher level attention. So we identified that, and at the third, based on the two, we are going to the IPC team, the IPC focal person and the IPC committee will come together in the presence of mentor, try to prepare improvement plan on the identified gaps expected before the next visit. As I mentioned earlier, the visit is every month. So prior to the next visit, the IPC team, the IPC focal person need to work on that specific improvement, in which I will share in a minute. So in how to use at the health facility level, mentors use this checklist to check the IPC practice. At least they need to stay, the mentors need to stay at least 3 hours at that facility, because as I mentioned earlier, it is, checking the document, the records, standard guidelines, everything, and also observations, because it requires observation in the hand washing, observation in environmental cleaning areas, observation in use of PPEs, and all this in the all what's practiced in the health facilities. So after 3 hours stay or more hours stay in that health facility, the mentors is expected to discuss with the IPC committees and the health professionals for the immediate solutions, and also improvement plan for long-term IPC, long-term activities or long-term issues. And the copy of this checklist is going to be left at the health facility, so that the health facility use as a self-assessment. They not need to stay for a month. The IPC focal person can use the checklist for the improvement of IPC in that health facility. So the checklist give opportunity for the record improvement, documentation, direct observation of the process of IP. In that is, as you can see, maybe just I try to screenshot some part of the checklist we use as a color coded. The first visit, this one is the first visit, this one is the second visit. Now we are on the second visit, so we record it. If it is, the service is not there, we record it as no, then we change it. If it is improved in next visit, we change it to as yes. So this is how we use the checklist at the health facility. So saying this, what the improvement in the facility? So far, we observed that the IPC committee, because IPC is a multidisciplinary or professionals, requires multidisciplinary professionals engagement, all the leadership and the staffs. So IPC committee can say that in this 52 health facility, the IPC committee start to prepare a plan, as you can see in the left side. Start to prepare a plan, minutes, so discuss and try to also avail small consumables to that level, and prepare to schedule for health facilities so that they can engage in different IPC activities. So mentors also link health facility with different partners. One of the problem in which I'm going to talk in a minute is the supply and the infrastructure issue. So mentors try to link the health facility with different partners, different government structures, so that they can have they can have support in which the project is not going to serve the areas that the project is not covering. For example, infrastructure issues like toilet, incinerator, which requires high investment cost. So assigning dedicated person for IPC, initially the IPC is not as such well focused, and the IPC focal person were not trained and not assigned. So the facility start to assign now the IPC, all facility, I can say all facility assigned, dedicated and trained IPC focal person for that specific institutions. So like installation of hand washing station, even though it is not running water, like a small bucket or using jars, and different solution is used for installation of this hand washing station at the entrance and the different service area in that health facility, availing consumables, as I mentioned. So improvement of documentation, like recording of data, like screening for COVID-19, staff training, registration, prepare of SOP. As a project, we drafted, try to refer and the Ministry of Health guidelines and all the global experience for standardizing of this TRAJ registration book, minute book, training registration, staff training registration book, and also adapt this SOP for facility. So in the left side, you can see the improvement plan that one of the facility prepared, just major finding areas, agreed action point, and responsible body who is going to deliver that by what time. So this kind of improvement plan is prepared at the facility level. So this what thing that I can share as improvement. So maybe in using this checklist, what indicator is going challenge us as a country to achieve, and also maybe I will talk some part as not inside of the training, in the side of the training, in the indicator, rather in achieving in our progress as a country. So maybe to start on number 2, indicator 2, it talks about the assessment and the management protocol, in which health facility is expected to have the risk assessment and the management protocol guidelines or checklists. It's unfortunate that a lot of health facility not developed this, but I remember it is in March 2019 or 2020 or 2019, WHO produced this risk assessment checklist. We include this in our training, encourage health facility to adapt this risk assessment and management protocol. The health facility knows what risk is there and how they report to their supervisors or the next level of surveillance team. So this indicator is a little bit challenging to achieve. The indicator is very nice. Maybe it is, challenging to achieve because it is not well adapted at a country program. And coming to the indicator 3, it's like personal trend in place for triage. As you can see, this is the support from the first phase project. You can see on the top of the canopy, this is very nice canopy, which is supported by the project. So unless we have dedicated trend and the dedicated staff under in this triage, it is not going to be challenging. So one of the challenge, the challenge is not in relation to the indicator, rather the country program, overall country program, like shifting or rotation. Some of the staff is well trained and some other are not. So while we observe, while we record or observe the triage system, sometimes we have a response from monitors that not trained, not dedicated staff is in place. So this is the country now due to some of the program is going back to the normal. So staff assigned here not have some sufficient training and have dedicated their time full time due to the shifting. So it's sometimes misleading. So some of the problem is related to assigning security personnel to check only the temperature using this infrared thermometer. Checking the other sign and symptom that the client or the patient maybe missed at the triage station. So this requires a kind of more intervention. So it's challenge us a little bit. Coming to number 7 or indicator 7, it asks us about the training of health professionals in standard precaution, airborne precaution, droplet precaution, the contact-based precaution. Currently, the country standardized the training PowerPoint or the training material. It's fortunate that the training material addresses all these areas, including dosing, as you can see on the screenshot of the slide. So it addresses all this. But in this indicator, what we face as a challenge on this indicator is it asks us like 6 months. So the indicator just encourage us to check the registration. As I mentioned, a lot of facilities has no this kind of registration, staff training, registration, and the HR system is not well strong, and encourage to randomly ask staff on basics of IPC. For example, if we ask staff who are not trained in the last 6 months or new staff, the probability of getting no or not trained is there. So we faced a little bit challenge on this indicator unless we try to put a kind of phrasing staff staying in this facility for the last 6 months and attended the training, have a kind of what kind of basic skills can he perform kind of thing. Otherwise, the indicator is very nice. The other indicator is indicator 30 and indicator 15, which we face a challenge in observing all things. As you can see from the indicator, it says, using of medical mask and surgical mask at all time when they work in the clinical areas. So in regard to the mask, we try to observe, the monitors or mentors try to observe the health professionals surrounding all in the health facility. At least 50 observation is recommended to not be biased. But it says clinical areas. In some of the clinical areas, it's not allowed to the monitors to jump in, to enter. So like deliveries and surgeries and different area of the clinical setup may not allow to enter. So this may be one of our challenge. Similarly, in case of 15, indicator 15, it says, Google and the face shield all time at the clinical setup. Practically in some setting, like delivery, as I mentioned, minor operations, some wards and counseling area, because it requires privacy, is kind of challenging us to track this indicator. The indicator is very nice, but to track this indicator is a kind of challenging us. Sometimes it's a shortage of this PPE and also discomfort. For example, we advise people, unless there is a aerosol generating procedure, we advise people to use just medical or surgical mask, but this face shield and the goggle is not well preferred by healthcare professionals. So as a feedback we collect from the facility, the checklist is well prepared and this is well detailed and the help for IPC improvement at the facility level, I can say that. And it's a practical and the giving opportunity for just to build good mentorship skill for mentors and also ground level soldiers who's going to be mentee or the IPC committee at the facility level. Even for regional and national staff, the checklist is very, very nice and practical. And as we have weekly based discussion on the checklist and findings using this color coded dashboard to easily observe the progress. it helps the mentors, and sometimes we also invite the health facility leadership on our weekly discussion, in which they can see their facility improvement in regard to the IPC. So the mentors exchange learnings and also try to adapt, try to be perfect in area of using this checklist, and also look for local solution for that specific facility. So as you can see on the graph, these are some of the output of the checklist, I can say. So the checklist can help to easily identify what problem is there, like the shortage of supply, knowledge gap, in the inactive IPC committee. These kind of things can be easily identified using this checklist. So it is very nice and helpful. So some of the indicators are still not well practiced, as things going back to normal. As I said, strong control on the hand washing behavior change aspect, pre-screening registration on the entrance, and documenting triage registration on the entrance, reporting case to the next level, because now home-based treatment is well encouraged for many countries. Ethiopia is also encouraging home-based treatment with isolation. So as this is declining, so staff, healthcare professionals is now start to decline using or adhering to some of the practice. And the other point is achieving of some of the indicator requires some support, like very focused and specialized training and the supply of consumables. I know everything is not expected from the outside, the facility by themselves, and the country also needs to support the facility, but we observe this kind of challenge from the facilities, like infrastructure problem. The water supply is, using, they travel a lot of distance to fetch water. So internet is one of the problem to engage all the facility to the weekly based discussion, and the facility leadership with quality of the facility leadership need to be improved with frequent mentorship of the mentor and the country. So overall, this is what we have an experience. We are glad to continue using this checklist and share our experience. Thank you. Over to you.
Thank you very much, Dejini, for that nice presentation. Participants on the call, please keep your questions coming in the Q&A chat. Our facilitators and experts are on the call to give you answers, as well as we will take it during the Q&A session. Dr. Garba, please confirm that you're on the call and you're happy to take over the next session. Dejini, if you can stop sharing your screen as well. Thank you. Dr. Garba Bello, please confirm that you are ready to speak. Otherwise, we will move to the question and answer session. So on that note, I think I will hand over to Anna to take us through the moderated discussions for the experts on the panel. And then we will take some of the questions on the Q&A chat as well. So over to you, Anna.
So sorry to intervene. Dr. Adamu is my name, and to take the Nigeria presentation. Sorry for this. I was made to understand that the meeting is commencing at 12 o'clock. Sorry to interject. If I may present on behalf of Nigeria, the Nigeria experience, right?
Yes, please. So over to you for your presentation as shared earlier today. So it's a 10-minute presentation. Over to you, Dr. Bello.
Sorry, this is not Dr. Bello. This is Dr. Usman Adamu.
He's representing Dr. Bello.
Okay, fantastic. Over to you to share your screen. Dr. Usman, over to you to share the the slides for the talk.
Co-host.
All right, so thank you. I was supposed to be one of the panelists, I think, presenting on behalf of Nigeria. So I will seek permission to share my screen. Can I do that? Yeah.
Yes, you have access to do that.
Okay, so is my slide being seen, please?
Yes.
All right, so thank you. Good morning, colleagues, and apologies again for coming in late. As I said, I was made to understand that the meeting is at 12 o'clock Nigerian time. So I'm going to take you through the Nigeria experience, going through the COVID-19 checklist for PHC facilities in action. And the outline will be looking at adaptation of the COVID-19 checklist for PHCs and the initial rollout in this country, and the scale-up of the COVID-19 checklist of post-training monitoring of PHCs and data use for action. We'll also look at utilization of the COVID-19 monitoring checklists in a mentorship program, experiences from the field, impact of the checklist outputs and successes, conclusion and recommendations. Now, the checklist for primary healthcare was introduced in Nigeria July 2020 as part of PHC care worker capacity building projects. The PHC worker capacity building project was implemented by MPSCDA in collaboration with the African Field Epidemiology Network and support from RTSL. The main goal is to build capacity and improve knowledge and skills of PHC workers in order to respond appropriately to service provision while maintaining safe IPC practices during period of COVID-19 pandemic. The first version of the generic checklist for PHC provided by RCSL was actually adapted to fit the country context. And then there were additions of routine immunization indicators. They were modified, some questions to suit COVID-19 surveillance system structure at PHC level. And then it was also configured onto the ODK platform. Now, the checklist was actually piloted in over 1,300 facilities in initially 2 states, Kano and Ogun, and the federal capital, which were considered high risk for COVID-19 response post-training monitoring. And the objective was to assess capacity for COVID-19 response in those areas of surveillance, screening and triage, IPC, WASH, and risk communication. The map is indicating where those states are in the northern part of the country, in the north central, and then in the southwest. Now, during the pilot, the total number of health facilities monitored in the checklist for FCT in cycle 1 was 118 in Kano, 857 in Ogun, 306, bringing the total to 1,281. For cycle 2, in these 3 states, we looked at 1,350, while in cycle 3 is 1,362. Cycle 4 was 1,372, while cycle 5 and cycle 6 was 1,356 and 1,323 respectively. Now, the data was analyzed after each cycle. The gaps and best practices were identified from each of these thematic areas. And these gaps were actually flagged to the state primary health care boards for them to ensure they take action, and then we follow up for those actions. Now, scaling up the checklist for post-training monitoring of the PHC across Nigeria, we built on the gains from the monitoring. MPSCDA actually mobilized additional government resources to scale up this model. Across all the states in Nigeria. The monitors were trained on the use of checklists, and there was nationwide monitoring, which took place during the month of August, October of 2020. And then data was collected, analyzed monthly, and disseminated and used to actually advocate for support to bridge identified gaps. Now, the data was actually used for action at different levels. At the health facility level, the monitoring was actually strengthened COVID-19 surveillance at PHCs, and the data from monitoring was also helped to strengthen accountability. At the state level, the data from the monitoring provided insights into the COVID-19 response at the PHCs, and the data actually guided intervention, prioritization, and planning. And it was actually used as an advocacy tool to state governments at the national level and beyond. The findings were actually presented at the National Economic Council meeting and the Presidential Task Force or COVID team. And the data at the national level guided high-level decisions and policies on COVID-19 response in Nigeria. And it was actually put in a multi-country joint manuscript lesson sharing length on keeping PHC safer during pandemic. For phase 1, there was capacity building. For phase 2, there was PHC healthcare worker mentorship, and the strategic approach for phase 2 was mentoring and supportive supervision, the use of data for performance management, and then there were small facility upgrades. Regarding utilization of the COVID-19 monitoring checklist and mentorship, the checklist for PHC is currently being utilized as part of mentorship projects supported by RTSL in Kano, in Nasarawa, in FCT, in Delta, Oyo, and Ogun states. And the project actually covers 6 states, 105 LGAs, and covered 432 primary healthcare centers. The checklist for PHC is the major tool used for monthly monitoring activities in the mentorship project, which is structured as a hub and spoke approach model. The mentors administer the checklist electronically on ODK to the healthcare workers who were trained as IPC champions at the PHC hubs, and then the IPC focal persons at the PHC spokes. And the data were collected and guides mentorship activities and decisions of facility upgrades. The thematic areas on the checklist, as mentioned, is surveillance, screening, triage, IPC, environmental cleaning, and waste management, and then continuum of essential PHC services. Now, regarding experiences from the field on the use of these checklists, the development of innovative solutions to mitigate the impact of COVID-19 is not accomplished by intelligence alone. A guiding document plays an important role. The COVID-19 monitoring checklist has significantly actually played that role. And this is from one of the mentor in one of the LGAs in Kano State. Now, this picture is actually taken at IPC in PHLG of one of the states. During the monitoring activities, lack of a holding area was identified as a key gap in screening and triage. So the IPC champion actually converted an immobile ambulance to a holding area for suspected COVID-19 patients. Now, again, the tool is user-friendly and questions asked are very clear to both the mentor and the mentee. The tool actually captures fully the IPC concepts that needed to be instituted in health facilities to prevent disease outbreak. And this is from one of the mentor in Dala LG of Kano State. And the picture on the left is showing the mentor and IPC champion using the checklists on the field. The checklist is very interactive, user-friendly, and novel, safety tracking and form that guides mentors to check PHC staff in service areas, every IPC effort made over the period. Each section of the form enables health staff, facility staff to know who and how to screen, when to isolate, and where to notify of COVID-19 suspects while keeping safe during daily delivery of services. The PHC data component enables staff to actually dig deeper into the past health records to see the levels of access and utilization of services for better environment. This is from one of the mentor in Buhari Area Council of the FCT, and the picture shows the monitoring using the checklists has catalyzed improvement in triaging at one of the PHCs at in the FCT. Now, regarding the impact, there is a significant improvement observed in core IPC indicators over 3 months. using the checklist as part of the mentorship. From line diagram, you can see the baseline, the first cycle, and the second cycle. And the variable that were used actually presence of IPC professionals, functional infrared thermometer, functional non-touch thermometer in use, surgical mask availability of waste bin, availability of triage. And the table shows the performance in some of the PHC taking into account the core indicators for the period over 3 months. Still on the impact, the data generated from the monitoring is summarized in a monthly bulletin. The bulletin is utilized as follows. The tool for advocacy to the state governments and partners to support bridging, key gaps identified, and then the data also inform planning at national, state, and LGA level for more targeted intervention to strengthen the response and the platform for information sharing on the best practice. And this is the bulletin as indicated. Now, in conclusion, the use of COVID-19 checklists of PHCs in Nigeria has contributed to strengthening the surveillance and IPC capacity at PHC level. In the context of COVID-19, these gains can be leveraged in future epidemics. The checklist serves as a valuable tool to inform advocacy, planning, and decision-making at all levels. Our recommendation is adaptation of this checklist to local contexts, serves as a useful resource for other countries to inform planning and decision-making for a more robust COVID-19 response. We appreciate MPSCDA and the project support team, RTSL for tech and funding support, AFNET for all the support, the state's primary healthcare boards and ministries of health of FCT, Kano, Ogun, Delta, Nasarawa, and Oyo State. And then, of course, the mentors who have provided the support in the implementation of the COVID-19 checklist, and then the healthcare workers who continue working at the front line to provide health services in the midst of COVID-19 pandemic. Thank you, everyone, and I'll stop here, perhaps to address if there are questions. Thank you, and over.
Thank you very much, Dr. Usman, for the presentation. Over to you, Anna, for the question and answer.
Thank you very much, Dr. Wande. I'm going to open up the questions and answers that we've got at the moment. There's a few that are in French, and I'm going to ask Anthony and Tim to maybe just help us with putting the question out there so that we can hear the panel if they can maybe answer for us. The one from Willie, Anthony, between you and Tim, if we can just maybe just read out the question and ask them to present for us, please.
Yeah, so for the first one, more so just an intervention being done. I'm not sure where Willie is from. Sorry. And here they're just saying that the mask wearing has become obligatory now, and that they will even start taxing those who do not wear their masks. So I'm not sure where that actually is, but it seems more of a stronger approach to try to encourage mask wearing, as many people have also commented in adding to this that they face a lot of challenges with the community not respecting mask wearing, and that they often face a shortage of supplies to wear the correct masks themselves to protect themselves. It's also been very hard for communities working with patients and getting them to follow the right rules when they lack the resources, but they also choose not to abide by the rules. And people have been asking for suggestions on this. So I'm not sure if there's anything the panelists want to add on this discussion.
Dr. Nicole or Prof. Shadai, do you want to maybe mention something on that?
Thank you very much. Nothing much except to say that I think people are getting COVID fatigued. So we're going to have to find ways of encouraging them to continue to follow the IPC rules. The problem on one side, that people have been vaccinated and feel, if we've been vaccinated, why do we still have to wear this mask that they really don't like? And on the other side are those who have not been wearing masks per se and have not caught COVID. So there's a belief that they're somehow immune. So I think we have a challenge to continue to find new ways of you know, and I think the psychosocials might need to come in, and the sociologists, how we can continue to motivate people to do their work, I mean, to wear their masks and keep to the IPC. People are getting tired. It's been a long time, you know, so it's just a comment. It's not, it's just what we're seeing.
Thank you, Prof. Should anybody else from the panel that want to just maybe add or comment on this? Okay, so the next one I'm going to, I see Anthony said that he wants to answer this in person. The person we're asking, I don't see any correlation between IPC and continuity of essential health services or any value of the section on continuity of health services in the checklist. So over to you, Anthony. You said you wanted to answer this live.
Yeah, I'll start, and I would really welcome Ebeth, Sade, Dr. Nicole, anyone else to jump in. I think the obvious connection here is that, you know, during the pandemic, there can be an impact to essential health services. And what's important to note is to what extent that impact is happening. And I think we can't necessarily just put it by the wayside and think that we shouldn't care about these other services and what's happening there. And so I think there is something to be said about understanding that that devastation to such services, what that looks like, and how that can also help inform the decisions being taken at various health facilities to see if they can help continue those services in a safe manner, thinking about how well they're implementing IPC practices. We know that if adherence can be high and strong to IPC practices, there's a lot of things that we can do safely. But we also need to understand what the pandemic is impacting currently in the health services that we're providing, because if we're not providing the essential health services, then obviously there can be fallout from this pandemic that isn't necessarily COVID specific, but indirectly. So I'll stop there, and I welcome any other comments from other colleagues on the panel.
Thank you, Anthony. Ebeth, I see you've raised your hand.
Hi, yes, thank you. Also just to say, like, there is a direct correlation between infection prevention and control and essential service uptake from patients. It's actually very well documented in the literature that during acute emergencies, what often happens is that resources get shifted or get shortchanged in essential service departments to other departments to try to address the acute emergency like an epidemic. So what happens is HIV, TB, any sort of infection prevention and control resources has the possibility of being shifted, and therefore making those departments and those facilities that focus on those service delivery platforms very vulnerable. And when those services are more vulnerable and not as safe from an infection prevention and control perspective, patients won't go to those services. The literature states that when patients do not feel safe in a healthcare facility, they will not go to that facility. So during an epidemic or a pandemic, if we neglect infection prevention and control in essential service facilities or departments, we're doing ourselves and our patients, most importantly, a disservice, because then we are sending them the message that we don't think that these services are as important, and therefore we're not providing them a safe environment for which they feel comfortable uptaking those services. Thank you. Over.
Thank you very much, Ebeth. The next question I'm going to appoint to Dr. Wande and the people on the panelists, but if Dr. Wande can maybe answer. They were asking, is there a possibility to formally share this checklist with the higher senior level health author at the country to be adopted by the head IPC department, as we are not officially in charge of IPC now? We hope all member state ministries of health have this checklist. Anything from you on this, Dr. Wande?
Yes, fantastic. Thank you. So ideally, member states have received the link for this checklist when it was published. As per our COVID-19 sort of communication mechanism, every week we're able to share newly published guidelines, documents, along with our weekly EPI brief and activities that we are doing. So through the Ministries of Health as well as the National Public Health Institute, this sort of communication or communique has gone out to the focal point. So ideally, whoever is representing the sort of the focal point for the countries through the Ministries of Health or MPHIs would have received this checklist. Indeed, I think I definitely, this is why we are having this session. It's really to encourage many more countries to start to adopt and adapt this checklist and several other tools that we have available. So yes, we will continue to do this again through our RCCs to communicate with the Ministries of Health. Over, Anna.
Thank you, Dr. Wande. I don't know if there's anybody else that wants to mention something from the panelists. Jenny, you wanted to say something?
Yeah, in regard to sharing to the national or the higher officials, we as a country in the first phase try to organize our experience. The Dr. Yewande from Africa CDC also part of our discussion during that time. We try to share the finding of the checklist and also how we used that checklist, and we encourage Ministry of Health to adopt that one, because from the Ministry of Health also participated in that reflection meeting, high-level reflection meeting. So currently also we are planning to engage all the country-level decision makers so that they can see what's going on and how this checklist is going to help. So this process may help for the country to adopt this checklist. Yeah, over to you.
Thank you, Jenny. I just want to, the next question is actually for you as well, Jenny, if you can maybe answer. They're asking, what is the Ethiopian experience? How sustainable is the IPC activities being envisioned? Thank you.
Yeah, actually, in regard to the checklist sustainability, not only the checklist, in the regard to sustaining IPC in the country, IPC is not well strong as similar to other countries. IPC is not well strong in our country. Currently, Ministry of Health with different partners working or interested in the IPC try to develop national IPC strategy for the next couple of years. So sustaining IPC will start from the guidelines, from policy, and from financial support from the ministry and higher officials or regional health bureaus. So our experience will be one of the inputs for the country IPC program, so that we are sharing the experience from this project and other experiences from different corner of project implementation. So now we are establishing different societies who are really concerned about infection control programs, intervention programs. So yes, it requires efforts from different professionals from where they are. So sustaining IPC I believe will come through time with high engagement of higher officials, with frequent experience sharing for the country. But I can say it is timely to share with Ministry of Health to include in this strategic document and frame on the sustainability aspect. Yeah, thank you.
Thank you, Jenny. I'm going to post the next question to Dr. Usman, if he can maybe answer this one. They said, despite the fact that this assessment has been made to different types of health facilities and the gaps identified, including action points and responsible person to rectify this, no action has been made. So why is there not taking care for speedy response? What do you think is the reason why there's not really any big difference made in most of the facility? Dr. Usman.
All right, thank you very much for that question. I also saw it in the chat box. I think the key thing to note is that our country runs a tiered system, and that's national, state, and LGA. And each of these levels have responsibility, but the national, as a matter of policy, we try to derive. We have a forum, a platform for coordination of all of these activities, including IPC, engagement with the chief executive and secretaries of the primary health care agencies and boards of the state. We meet every week. And if we know for sure which facility actually is being referred to, perhaps these are some of the narratives that will bring to that platform to ensure that those issues are followed up and then compliance is strictly monitored. Otherwise, IPC is here to stay. Even post-COVID, there are other airborne diseases that will definitely be prevented through the continuation of the, especially by health workers. So for us, it is a system of advocacy, right from the national, state, and LGA. The primary healthcare level is at the LGA, but through the primary healthcare boards, we will know for sure which facility, which LGA is referring to, for us to direct that concern to the executive secretary to the State Primary Healthcare Agency to immediately ensure that actually action is taken. Thank you and over.
Thank you very much, Dr. Usman. Anybody else that wants to make that as well that has been working? Chioma, you, Anthony, or Jenny, or Dr. Nicole?
I would like to hear maybe from Dr. Nicole or to Jenny. This is a common problem, obviously, in the work that we undertake with them and that we have at the facilities. So any additional comments? I'm not sure, Dr. Nicole?
In relation to the comment, this tool is capital for the health facilities, but also for the health suppliers and for the others. And it's also essential about the well-founded for the service provider, also the improvement of the standards in relation to prevention. And that's the usefulness of the tool that we use in the assessment. It's a tool which is going to become a lasting tool for us to be able to capitalize on the acquired knowledge. And that's what I can say about the tool itself and the importance that it plays in our programs.
Thank you very much, Dr. Nicole.
Merci beaucoup, Dr. Nicole. Thank you very much, Dr. Nicole.
Chioma, I'm not sure, do you want to maybe also mention something on your experience?
Sorry, and my internet dropped off, so could you just, I just got back in a few seconds, if you would like to repeat the question so that I understand.
So they were just, okay, thank you, Chioma. They were just asking, why is it so difficult to see any improvements happening even after the gaps have been identified? If we know and understand maybe the reason behind that, if you can maybe share your point on view of that.
Okay, I think what I would say is that we've all agreed that IPC is at its infancy. What I mean, having been a routine practice other than a response approach, you know, in Africa and most of our settings, it's come out very clearly in most of the discussions here. So I think one reason why the improvement might be difficult to see is when there isn't proper engagement of, first of all, when there isn't data to actually prove what you want to, what you're trying to advocate for. And then if there is no proper engagement of the ministries of health or partners. So for us to have sustained improvement from gaps identified and sustained practice, I think one of our foundation and how we started on the little project and expecting expansion in countries, which is actually one of the things we're achieving on this webinar today, is first to begin to even have this data, because the data you can make a case for IPC, and the little and the subtle improvements that have been seen can be communicated, you know, and all that will make a case for IPC. And with time, I believe that powers that be, or the authorities, now in this case, ministries of health in country and partners, will be able to understand and see that, and most part of it, IPC can actually be done without a lot of capital intensive investments. where you have more of the investment would be more of an IPC suppliers. But in practice, we always encourage locally adaptable innovations to get things done. So I think where it might be lacking is where we haven't had the proof or the science to show that IPC works. But I believe that with the way we have gone so far with experiences on the use of this checklist and the project involving the relevant partners, that will ensure the sustainability. And I believe it's a work in progress, and I will get better. We'll get better. Thank you.
Thank you very much, Chioma. Edith, you've said that you want to answer this question live for implementation of IPC in the primary health center, whereby a healthcare worker uses one glove in vaccinating more than 20 babies. What is the best procedure to use? Edith, over to you.
Yes, hi, thank you, Anna. So during vaccination campaigns or hubs, including vaccination campaigns for COVID-19, it is not required to wear gloves during the actual vaccination of patients. In fact, you could potentially spread germs if gloves are worn improperly. The only time you would want to wear gloves while you're providing a vaccination is if the healthcare worker is at risk of coming into contact with bodily fluids while giving the actual vaccination. It is also important to note that while it is not required that you wear gloves after providing vaccinations, it is very much required that you engage in hand hygiene in between patients while vaccinating them. Thank you so much.
Thank you very much, Edith. And I think we can all echo that. I've got 3 questions that is in French, so I'm going to hand over to Anthony or Tim to maybe just read them in English so we can maybe get some feedback onto that. Over to you, Anthony.
Yeah, so the first one here is more of a comment. Hello, I am Mr. Foda. I am from Cameroon. Thank you very much for the presentations. Here, all the services are not really appropriate to manage a case of COVID-19, and the negligence of some health centers, despite the will of some people to eradicate this pandemic. And I think it would be still necessary to inject a lot of means to stop the spread, especially in the urban areas. So I think we can all agree that there's definitely investments that need to be made, and that advocacy is something that still needs to continue at a high level. We've had many participants chime in that materials are lacking in their facilities and that they don't even have masks to use. So we know that there is a global shortage on this, with much advocacy to be done around this. Before I read the next one, I'm not sure if there's any panelists that wanted to contribute or add anything to our fellow colleagues' comments.
Nothing from my side.
Okay, I can go on to the next. The next one is from Ibrahima Kuma. It has been more than a year since I participated in these Africa CDC webinars on IPC. Until now, in Cote d'Ivoire, many people of the Ministry of Health are officially unaware of IPC at the basic level or the lowest level. So it seems like, I think what we said at the start of this, and I actually really welcome this comment from Ibrahima, is that the primary healthcare is forgotten probably globally. I wouldn't say it's something maybe unique to Cote d'Ivoire. I think we've seen this in a lot of countries, and I think there's even more reason and emphasis to that. Enforcement at the primary healthcare level is really fundamental, because we know this is the entry point to healthcare, and there's a lot of preventative care that we can be doing for patients, for the community, that will actually help alleviate stress on the higher levels of healthcare. And so having good reinforcement at this level is particularly important. So I'll stop there and see if any panelists wanted to add anything on this point.
I think I just want to agree with you that really the primary health care facilities have been largely, ignored, if I may use that word. But that's what we're trying to solve now, and it's going to be a long haul, because they're the most numerous in any country, and they're the ones closer to the people. And I think, and they are probably the least resourced in the three levels. So there are lots of challenges at this level. But now that we're shining the light on it, my hope is that we will not stop shining that light, and we'll keep working at that level where most people in the countries actually go to. So there's work to be done. And I think as we get more people into IPC and they see it as a system strengthening specialty rather than just for epidemic response, we might start getting some change on the ground. Thank you. Over.
Yes, thank you so much, Sade, for that comment. And I do hope that is a key point that people walk away with today and know that we are pushing this agenda even with this webinar. The next comment here or question is, and maybe this is one for, I don't know, I might come at you, Ebeth, with this one. Can the ministries responsible for human and animal health come to you, Ebeth, to start? And if there's anyone that wanted to jump in on this?
Hi, yes, of course. I mean, definitely. A lot of initiatives that are starting to come out are directly related to One Health, and One Health encompasses both both human and animal population infections, particularly focusing on zoonotic infections, or those infections that spread into human populations from the animal population, as well as looking at antimicrobial resistance. So, you know, a lot of ministries of health may not necessarily have a One Health department or initiative yet, but they may have, let's say, an AMAR focus, or they may have an IPC division, but they may not have, let's say, a sort of a zoonotic infection or One Health division. But most definitely, in countries that have these two departments, it's highly recommended that for a well and robust IPC program and a national program, these two pillars must work together in conjunction with each other. They most definitely cannot be siloed. Over.
Thank you so much, Beth. And I think I saw one day.
Yes, that's me. So I was just going to say, and to re-echo what Ebeth has said, indeed, many of the issues that we are currently addressing requires a One Health approach. And I was just going to share that, at least at the level of the African Union, what you would consider infection prevention and control in the agriculture sector, which is called biosafety or biosecurity. Technical agencies at the African Union level, Africa CDC, as well as AU-IBA and AU-PANVAC, are already working together in a multi-sectorial approach as well to develop frameworks, operational tools around addressing this in the agriculture sector.
Thank you so much, Wande and Ebeth. I will move forward and I will keep going until Anna tells me I can't.
And I need to tell you that I think we will need to stop. We are already nearly 10 minutes over our time. So if we can maybe just wrap up with the last one, and then we will look into this and answer them by email or privately. If we can just take it from there. Thank you, Anthony.
Okay, I'll be super quick. I'm going to sneak in these two because I think they're kind of similar. The next one is from Jean-François. He says, I would like to know if all countries are involved. I presume this is asking about this work that we're presenting today. The work that you've seen is mostly from the ICANN project, so with Ethiopia and DRC in particular, and we are presenting our current use of this. And we also heard from Nigeria at a sort of higher level as well, how they've incorporated it. I do believe Wande mentioned earlier that this tool will be shared broadly and has been shared with member states so that they can have it and use it and involve it, but the work that we present today were specific projects with specific funding. And then lastly, just to finish off here, Again, similar kind of vein of talking about supplies and how to approach when there's shortage of masks. During our supervision in rural areas, we find some families of more than 7 people who have 3 masks for the use of all. This practice is frequent. I would like your comment on this. I think at the end of the day, I mean, I don't think anyone, one of us here will say that we should just be sharing our masks among other people to use within the family, but we can sort of respect the fact that the reality is there's a difficulty in everyone having a mask to use individually. I think what we can maybe add to this discussion is that when people come to the health facility, it is a health facility and there are slightly different rules than what may happen outside of it. And it is important to enforce safe IPC practices within your institution. And if there is the availability within your health facility to provide masks to those that are entering, I would suggest doing so to ensure that there is safety all around you. But I do welcome any other comments from the panelists to help maybe speak to this sort of shortage and maybe approach for healthcare workers when faced with such scenarios. Over.
I think you said it well. That sometimes it's really beyond what we can do in the community. The only advice I would give, if possible, and I really don't know how, is maybe even if they don't have masks, they should use scarves, you know, around their faces. So even though it's not done up like a mask, there are lots of fabric masks. So if they're in the community, they can just wear, you know, a bandana or something over their faces. In the healthcare facility, we need to be a lot more stringent. And I think having some form of support for people coming will be needed. Unfortunately, again, at some of these primary health facilities, they don't have the resources. So I think it might just be that they will mention to people that if you're coming here, you must have your face covered. I think that will probably be the best that they can do. And they can suggest, you know, the fabrics that they can use, tie it around your face, even if it's not drawn up like a mask, or, I mean, cut up like a mask, as long as it's filtering over your face and over your nose and mouth, it will suffice. I think that's the best we can do in such dire circumstances. But if you can give them masks, perfect. Within the community, tell them to wash their masks if they have to share, or use fabric. Many of us use what we call the wrappers, plain fabric cloth, and they can just cut a little square and use it in addition. Thank you very much.
Thank you very much, everybody. And I need to close us up with this last one. If there's anything else, please connect with us and we can continue this discussion offline. I want to thank everybody, and I want to thank the panelists and also the French interpreter, Tim, for spending time with us. Thank you very much for all the questions, and please connect with either Africa CDC, ICANN, or Resolve to Save Lives if you have any more questions. Thank you very much, and have a good afternoon.
Recording stopped.